It's been nearly a decade since Dr. Julia Haller published her inspirational editorial, Cherchez la Femme, in JAMA Ophthalmology. Since then, she and her team have been tireless in their pursuit of diversity in the field of retina, particularly within research, authorship, and editorial positions. So where are the women now? I'm Rebecca Hepp, Editor-in-Chief of Retina Today, and you're listening to New Retina Radio, brought to you by Retina Today and Bryn Mawr Communications. Today, Drs. Adrienne Scott and Steve Sanislo are talking with Dr. Haller about the state of affairs in retina and just how far we have come and how much is left to do. Adrienne, Steve?
Thank you so much for that introduction, Rebecca. I'm Adrienne Scott. I am Associate Professor of Ophthalmology at Johns Hopkins University School of Medicine, Wilmer Eye Institute, and also Medical Director of the Wilmer Bel Air Satellite.
Hi, I'm Steve Sanislo, Clinical Professor of Ophthalmology at Stanford University Medical School and at the Byers Eye Institute at Stanford.
I'm Julia Haller. I'm the ophthalmologist in chief here at Wills Eye Hospital in snowy Philadelphia, and I'm a retina surgeon.
Well, Dr. Haller, it is an amazing honor to be here with you and also with colleagues to discuss our important work on diversity in the field of retina. And I'm truly honored to have this conversation with you. I remember reading in 2015 your editorial in JAMA Ophthalmology, Cherchez la Femme. And it was one of the first times I'd read an article like this at one of the, high impact peer reviewed journals. And I was inspired because I thought if Dr. Haller and her stature is noticing a problem and identifying a problem and offering solutions and bringing this to the attention of our field, then this is a very important situation, and it really heartened me as a woman starting out in the field of vitreoretinal surgery. As we look back almost 10 years later, Dr. Haller, what is your perspective about where we are now compared to where we were when you first penned that article and had that idea?
Well, Adrienne, let me say that it's an honor to be speaking with you too, and congratulations on all the incredible work you've done, both advancing clinical medicine, but also in the field of disparities. I think we've made progress. I think one important piece has been recognizing that there's an issue and then starting to measure it and get some metrics so you can start to think of ways to impact things. And in that editorial to which you refer, I looked around for examples of journals and outside our field of medicine where there had been efforts made to expand the number of editorialists, and it was very clear. And it seems so obvious but you don't think about it until you actually study it. All of us, when asked to nominate someone for a role, we think of our own friends, we think of people we know. And so to the extent that there have been fewer women, fewer people of color in the field, the existing hierarchy really didn't know a diverse group of people to ask. And it takes work, it takes intentionality, and it takes specifically making an effort to expand who you know and who you might ask in order to achieve change. And so I think it's very encouraging that when we measure things and then we look to see when there are differences, can we identify reasons for differences? Maybe we can advance the cause. So I wrote that. Neil Bressler was editor of JAMA Ophthalmology. He asked me to write that. And then later, we did a study. Sharif Fathi, who's a resident here and then was a fellow in cornea at Wilmer, did a study where they looked at editorial, and I was actually a co-author too. We looked at editorials and the increase between the 2015 to 2019, up to the 2015 to 2019 group. So taking the cohort back when I wrote that original editorial and then afterwards. And there was a definite increase in the number of women editorialists. And that increase was led by JAMA Ophthalmology. So I think we have to have a shout out to Neil Bressler here, because he's an example of an editor who really made an effort to include more women, and it worked, and there was a ripple effect. Now, was it just due to that? No. Obviously there were more women in senior positions. But I think it does come down to individuals and our responsibility to make the world a better place, because we can. When we looked in another study that Jay Sridhar pushed, we looked at the presence of women in podium positions. So, another thing where you're asking people to speak and choosing people and so we looked at the how many women were in podium positions, and this was just in Retina. And over the 2015 to 2020, 2019, I think, time period, there was not much of an increase, and it languished at about 24% rate. As we looked at the numbers and specifically looked at who was on the program committee, if there was at least one woman on the program committee, there was significantly more representation. So, that's another little index of where you can make a difference. But again, you have to get the women in the leadership roles. I mean, when I took this job, there were only 3 women chairs in the whole country. And I was the only female president of the American Society of Retina Specialists for like 15 years, before Judy Kim was the second one. So we've been few and far between, and in the in journals, there are very few women on the editorial boards relative to men, and 0 editors in chief. So, there's definitely room to move there. Another thing we did was look at the literature, and this was something that Ankur Nakar did, who's applying in ophthalmology this year, and working at that, and I was a co-author on this, and looking at 25 years of Retina publications. And we did find a significant increase in women in first authorship positions, and also in senior authorships. So, and if there was a woman in a senior author position, it was much more likely to have a woman in the first author position. So again, I think leadership, mentorship are recurring themes that come across in all areas of diversity. And again, it's important to measure things. It's interesting when we look across specialties. Retina seems to be leading, so we can be proud of our specialty. If anything, we're punching a little above our weight there.
Well, Julia, I think that the way that you approached that research way back when in 2015 was really great, because a lot of people were just talking about the number of women in retina, let's say, or the number of women in ophthalmology or surgery or anything, but they weren't necessarily specifically looking at in sort of leadership positions or influencer positions. And so I think what's so remarkable about your work and the work that you cited in that editorial is looking at that and looking at, who is making the decisions for, invited editorials, who is reviewing papers and that sort of thing, and being editors. So I think that's very great. And I'm really encouraged to hear that you've have data showing things are much better. I mean, obviously we're not where we want to be, but the fact that it's improved is really encouraging. I'm kind of curious, what you feel like are the next steps for your research. What else do we need to know to help make things better and elicit change in our field?
Well, the good news is there's lots of room for research and lots of interesting things to talk about. The bad news is there's a problem, right? But I mean, we've been interested in a number of things. I think when you talk about who's influential and who makes a difference, we're casting a broader and broader net. What Ashvini Reddy at Hopkins spearheaded a paper looking at who had industry relationships. Now, like 30 years ago, that would have been totally it would have been who's tainted with industry kind of. Now things have really moved. And, who is on these KOL boards, who's considered worth engaging as an expert by startup companies and having on scientific advisory boards is actually kind of a feather in your cap. And so she did an interesting study looking at all the different relationships you can have, that you have to sign off on your conflict of interest. Are you on a speaker panel? Are you, one of the lead people who's the sort of the face of the new product? And she found that women were way underrepresented across the board in those positions. And actually that's one of the worst areas of disparities. So that may reflect maybe the intersection of the disparities on the industry, entrepreneurial, startup, and company side, as well as the disparities on the medical side. And even when women were involved, they were paid less because, this is reported through the Sunshine Act. So even the women who were part of it were paid significantly, were considered less worthy of money. So I think broadening the bandwidth with which we're looking at disparities issues is one thing that I'm interested in. But another thing is, how does this impact on patient care? And what are the disparities in the way we recruit patients? What are the disparities in the way we treat patients? And how do we make that better? And then by extension, how are we building a pipeline of ophthalmologists in general, but also retina specialists in particular, who are more representative of our patient base? Because I think what we're increasingly understanding is that having physicians who that you can relate to makes a difference, no matter who we are. I see it myself. If I'm seeing a dermatologist who maybe trained somewhere I did or knows friends of mine, I just feel more comfortable with them. And obviously that plays out across the whole spectrum. So we've done some interesting work spearheaded by Rebecca Suarez, looking at geographic census data and things like, for example, she came up with the idea of looking at all the clinical trials in a certain period in macular degeneration and seeing where they were located, and then looking at how hard it was to just physically get there. Because we know one of the problems with recruiting patients studies, if they can't get in, so what that study found was that clinical trial access was reduced for Blacks, Hispanics, Asians. It correlated with education level. So more highly educated people have more access, just geographically. This is not, nothing to do with their desire to get in. So education levels, rural and Midwest and Southern folks had lower access. So, all of the benefits that we know from participating in clinical trials accrue to patients. They understand the disease better. They understand, in addition to getting kind of state-of-the-art cutting-edge treatment and the potential to be in revolutionary new trials, and at least be educated, even if the trial doesn't work out, you get state-of-the-art care, you're monitored more carefully. I mean, I always tell my diabetic patients, you're going to get so much better being in the study, and you probably your hemoglobin A1C is going to get better because, everybody's going to be asking you about it and you're going to be thinking about it. So all of those advantages that accrue are meted out in an unequal way. We just did a IRIS database study of treatment in the first year after central retinal vein with macular edema diagnosis. And one of the nice things about the ICD-10 codes is you can code for whether the vein occlusion has macular edema too. And we found disparities in treatment across the United States. Women were treated less. This is in the first year. So we know that early treatment plays out in terms of visual outcomes. Women were treated less, Blacks were treated less, Asians were treated less, older people were treated less. And there was a sweet spot of 2040 to 2200 where about 75% of people are treated. It drops off on either side of that. So you know, if you're 20/40, people say, well, you know, you're probably going to be okay. Personally, 20/40 is not what I'd ideally like my surgeon peeling my epiretinal membrane to have. And then also, you know, we all have patients who are 2800 who can improve, and they're written off more than people in that sweet spot. So, you know, only 75% of people being treated in the first year for vein occlusions with visual loss and macular edema. You know, we know there's under treatment. You know, some studies have shown under treatment overall in age-related in wet macular degeneration. But it's interesting to see, you know, even after all these years of available treatments for vein occlusions, second most common cause of retinal vascular disease, there's under treatment and disparities, and you wonder why, and you wonder, you know, these big studies show you something, but then you go, well, where is it better, and why would it be better there, and can we drill down on things that can make it better? So anyway, that was a very long-winded reply. I think there's tons of challenges out there. Oh, here's another thing. The match didn't even record any information about race or ethnicity until 2016. So if we wanted to say, you know, let's look at all the female, well, we could do probably female, because you can kind of, you know, you have those programs you can figure out if names are male or female. But if we wanted to say, let's look at all the Black retina specialists who've been trained, maybe, you know, maybe there's no disparity in their vein occlusion treatment, but you can't do it because those people are just finishing their training right now. So we don't know what the outcomes are. And we don't have good granularity about, for example, Hispanic ethnicity. You know, we have to impute Asian ethnicity. There are just so many things that we don't have the granularity to understand yet. I commend the ASRS, you know, making an effort to have us all log in and put more in our profiles so people can understand us a little bit better, and maybe correlate it with other types of outcomes.
So that's fascinating. I agree with so much of what you said. And, you know, there is in this climate some pushback against initiatives that encourage, you know, examination of diversity, inclusion, equity practices. So if you, Dr. Haller, had to speak to your colleague who's designing the program for a major meeting, or your colleague who's designing, you know, the next panel, or the industry colleague who's designing the next ad board,
Yeah.
what is your advice, or why is this important to look for diversity? And they would say, well, I just want the best people. You know, I don't care about color or race or gender, et cetera. What do you say to those individuals that don't quite get why these things are important and push back?
Well, first of all, good point. And I totally share your dismay at what I view as a disastrous current climate that says things like anti-woke, you know, uses these huge generalizations to disparage totally legitimate concerns about disparities and diversity. I think the best way to do it is with data. And you know, of course, if you look at the population as a whole, that doesn't seem to be working either. I mean, you know, vaccine denial. I mean, it's a daunting environment. But one would think, at least in our professional community, that data, for example, from there was some nice work from a group at Wharton looking at board diversity and the amount of time spent deliberating on questions and the type of decisions that were made in terms of, and they had metrics for how good the decisions were, and they also had metrics for how much deliberation and research and time was put into them. Hopefully, you know, that correlated with the decisions being better. And if the board was diverse, it made a huge difference. And when you think about it, I think that makes sense, because if you're hanging out with your bros from college, you may all come to the discussion with kind of the same preconceptions, and you may come to like, yeah, that's the obvious decision. But I know myself when I'm around a table of people that I don't know, particularly if they come from different backgrounds, I do my homework more because I'm a little worried about how I'm going to show up at that table. And I want them to be impressed with my level of preparation and how much, because they don't know me, you know, that I'm coming as a really different person. So I've found myself that on more diverse boards, I myself push myself a little bit harder to be better prepared and to think about things and be ready for the discussion a little bit more. And that plays out in actual research and outcomes. And you know, other studies have looked at boards with more women and found that they've been more successful and delivered more shareholder return. So you know, I think you have to speak people's language and show them the data about where the rubber really meets the road in terms of the effectiveness of more diverse boards. It's not, and you have to push back against people using words like woke. Like, words really matter. There's a whole group of women leaders who have a campaign against the word bossy. Because bossy is used to disparage women who are ambitious. It's not used. Steve's never been called bossy. I mean, like maybe once, but Adrienne, probably you and I have been called bossy. You know, it's just, it's a word used to describe women who are ambitious, and they've made a movie about it. I actually show a clip sometimes in talks because it's very cute. And my favorite part is where Beyonce comes in at the end and she goes, "I'm not bossy, I'm the boss."
Love it. Love it.
So if you are the boss, that makes a difference. But you know, words matter, and I had thought about it before with women because, you know, words are said about them like they're too ambitious. That was said about Hillary Clinton. You know, she's too ambitious. She's strident. You know, last time I checked, she was up against some men who were equally ambitious and strident, but that was used to belittle her. And now I see it playing out in these debates about totally other areas, including pushes for diversity and pushes to combat things like anti-Semitism.
So Julie, I have maybe a quicker question for you to answer.
Yeah.
And you brought up that, you know, this does matter a lot because we are talking about treating patients. And, you know, one of the things is, I think we all look at the clinical trial data. It's very important, especially these very large clinical trials for FDA approval of drugs and things like that. And, you know, those trials are usually pretty balanced in terms of participants in ophthalmology, at least for male, female balance in the trial. But one thing it seems like we don't really see any subgroup analysis or planned subgroup analyses looking at male versus female outcomes and things like that. And I'm curious, do you think that's because it doesn't really matter in ophthalmology? Maybe men and women should be treated equal, all the same, or is it?
No, I think it's because people haven't thought to do it. So one of the things, and this is like 15 years ago now, when Bernadine Healy became head of the NIH, they worked on data looking at the clinical trials in general, and, you know, women hadn't been included. So all the information about treating for heart attacks, for example, cardiovascular disease, was all male centered. And I think it's pretty well known now that women have totally different or a host of different symptoms than men, and that the classic heart attack was the male classic heart attack. And the outcome of that was that women were being undertreated. Their heart attacks weren't being, you know, they would have all these cardiac complications that weren't being adequately treated. So I think there is a difference, and it hasn't been looked at. In our vein occlusion data, women weren't treated as aggressively as men in the first year, and that was in all subgroups of visual acuity. So it's got to translate into outcomes data, which is, you know, one of the things that we're interested in looking at. If you look at the burden of blindness worldwide, it is way disproportionately borne by women. So women have worse visual outcomes in terms of blindness all around the world. Now, why exactly is that? Is that because they're deprioritizing themselves? Is it they're taking care of their family ahead of themselves? Is it because they're not, physicians don't treat them aggressively enough? I mean, there are probably a whole bunch of different reasons, and it's probably different culturally in a lot of places as well. So, these are all really important questions, and I think you bring up a really, really important point. And it's one thing that we're looking at right now in the IRIS database with regard to macular degeneration. Of course, that's mostly a white, more Caucasian than, but the disparity. I don't know what the answer to it is because we haven't done the analysis yet. But I'm wondering if women are treated less aggressively than men there.
Thanks, Dr. Haller. And I've heard you speak a little bit before about your journey into becoming a vitreoretinal surgeon. And, for me coming up, I had people, that I could look at as role models and women in VR, yourself and Sharon Feckbrad and Cindy Toth and, my Wilmer mentor, Susan Bressler. Why did you, or how did you decide to become a VR surgeon? And what was that like for you in such a male-dominated, homogeneous field at the time? Why did you decide to kick that door in?
I came to ophthalmology loving surgery, and I actually did a surgical. I was a Halstead intern in surgery, and was all set to go into general surgery when I came down to Wilmer and spent a month with Stuart Fine. And I was already in my 4th year of medical school, so I actually it was too late for the match. I had to it ended up being great because I did a year of research in pathology with Fred Jacobiak. And so I was a late comer to ophthalmology. And the thing that was attractive to me about it was the surgical aspect. So I always knew that I was going to be attracted to surgery. And I think, all of us have mentors of different stripes. And in those early days, if you were a woman, you're pretty much had to have a male person who would take you under his wing. And Stuart, was early on. I mean, he was quite a recruiter of Hopkins medical students into ophthalmology, and even the non-Hopkins students who did rotations there. So he really recruited me into the field initially. And then, Ron Michaels at the time was, I think many people considered him the top retina surgeon in the world. And, I wanted to be that too. And then my senior residents, when I was a first year resident, Jean DeWan and Paul Sternberg were both going into retina surgery, and Jean would get me up the operating room, and I couldn't believe it. In my first operations, I just was going, wow, you can do this. This is just like awesome. And then, Arnold Patz was very very encouraging. He did mostly medical retina, and I really wanted to operate. And then Mort Goldberg was hugely influential and gave me a couple of projects, where I was able to give some talks and things like that. So I aspired to be like those people. And it took me a while to find my own voice. I remember interviewing the first time I interviewed for a chair position, and I was aiming for the Mort Goldberg. And like, if you know Mort, you know me, it's like, that was really not my voice. And I think it was when I realized that and became more comfortable with just being myself, that I had more success on that front. But anyway, I had, Bob Welsh. Dr. Welsh was the first person I did scleral buckles with, and he would tell me about Alice McPherson because she had been a fellow at Mass Eye and Ear with him, and he loved the Retina Society, which he had been one of the founding members of, and so he kind of instilled in me this desire to be part of that world. So I really had mostly male mentors, but God bless them. They were great.
Great, thank you.
Well, Julia, this has been a really interesting talk with you about gender representation and things like that. I'm kind of curious though, what are your thoughts on, research and studies regarding other potential bias in terms of other factors such as race or sexual orientation? It seems like things like that might be a lot harder because the granularity of data is probably much more difficult to find. But are you any thoughts on how we can look into that?
Well, I think particularly ethnicity is a hard thing. Like, we in that vein occlusion analysis that I just was telling you about, we expected Hispanic ethnicity, which shows up as a factor, to be a negative, but it didn't show up in our analysis. But we had like 30% of with no ethnicity data. So, when you don't have that data, that could make it way positive or way negative. You just don't know for the missing data. So I think we have to make more of an effort to figure out what we want to be studying and then try to collect that data. And I totally agree with you. I think any subgroup that you pick that's been marginalized is probably, depending on where they are and who's treating them, it probably does make a difference. And how to understand how that impacts on outcomes, which is the point you were making earlier, is so key. Ali Khan has been working with Genentech, and just think of their diabetic resource data. Lucentis, the first one, and so we looked to see if there was a difference in outcomes for Blacks treated with Lucentis versus whites, and through the whole and that huge database. If you looked by clinic, there wasn't enough it looked like Blacks didn't do as well as white. It looks like there were 5 or 10 letters difference, which is significant. But you couldn't be sure because when you did the multiple regression analysis, you couldn't control with clinics. There weren't enough patients enrolled at any one clinic to have enough numbers. And that's the whole database with all the DRCRnet stuff. Are you kidding me? So, we're just going to have to be more aggressive. There are examples of companies. Regeneron has been intentionally working, and the Witt-Buckle Society has been at the forefront of this. Jace Ritter, Basil Williams, a lot, and trying to work on getting people up to speed in terms of being clinical investigators and have clinical trials. There are companies, Bristol Myers Squibb, and I'm a director, so I'm very proud of this, has made a huge effort in cancer trials to have more trial centers in underrepresented areas. So instead of just Manhattan, you're also in maybe the area of the Bronx that is most heavily African American. And that's going to, I think probably there are going to be difference in outcomes. I'll tell you, one of the great talks I've on disparities was Eve Hickenbotham's Jackson lecture, which is archived, and I would recommend that to anybody. One of the interesting things that she showed from work of a professor at Penn is she showed a map of Africa. So we'll say African American, like that's one thing. So she showed the genetic variation around Africa, which is as great as, Iceland from Japan. So, to the point that you all have been making, there's so many levels of lack of knowledge and specificity and granularity that we currently have in our databases. I think, on the good side, there's lots of room for interesting work. It's immediately clear that we need to be intentionally promoting and recruiting a diverse group of people and casting a broad net and reaching down at younger ages. People show as late as 8th grade, you can make a difference in steering people into medicine. And what we know from studies of medical students from diverse backgrounds is they come in thinking primary care is what they're going to do because their example is their pediatrician or their grandmother's primary care person that they help take care of her with. And so they don't think of fabulous fields like ophthalmology until they finally get exposed, if ever, in medical school. Some great both of your medical schools are great examples of where, the medical students do get good exposure, but there are plenty of medical schools where they get almost no exposure. And so, fourth year, they've been told, okay, do community stuff, spend your time volunteering in clinics. And suddenly it's fourth year and they go, no, too bad, because you should have been writing papers and taking time off to study and get a 10% better score because you don't have any chance at all now. So, we need to do better than that.
Well, Dr. Haller, we very much appreciate your thoughtful comments and your expertise on this important topic. And I could just listen to you chat about your experiences and your perspectives for forever. I think that it's just been an honor to speak with you on behalf of Steve and Rebecca here. Do you have any final comments about where we are as a field and just some final take-home pearls for our retina community as far as where we are with diversity and inclusion and how we can keep moving the field forward?
Well, I think, first of all, the fact that we're having this discussion, I was asked to do lots of podcasts 10, 15 years ago. None of them were on this topic. And really, it was just, 2 or 3 years ago that I gave the first diversity, equity, inclusion talk at Retina Subspecialty Day that had ever been given there. So, we're late to the game, but at least we're starting to be there. So congratulations. I think that's making a difference, and it's on our radar screen now, and it needs to stay there. I think the type of leadership training that we're increasingly doing in ophthalmology is really important too, because everybody needs to be a better leader. And part of leadership training is learning how to harness, a diverse workforce and get them inspired and also to be ahead of the curve in terms of seeing where you've got gaps and where you can make improvements. And shout outs to retina groups, but also women in ophthalmology. That there was no women in ophthalmology or women in retina when I was coming along. And now those groups are specifically talking about leadership, talking about mentoring, talking about, if you want to be a PI, even though you're in private practice in the suburbs, you can do it. How do you do that? Who do you have to connect with? And those messages are really important. And then the other message I think for young people is get the best training you can possibly get. Work really, really hard to be excellent. And then that is the basic building stone. That's gotta be the foundation. And that is there's no substitute for that. So absolute clinical mastery and excellence. And then there's so many different ways you can go, and there are a lot more options out there for mentoring and leadership training, and I think people can aspire to that on every level. Be it local advocacy for your patients in your medical society, subspecialty groups, young ophthalmology group for American Academy of Ophthalmology, all the way up to the top. So there are many opportunities out there, and I'm very encouraged. We just had our open house yesterday with applicants coming in, and you guys are you're getting more senior than you used to be. So, and I'm way more senior than you, and I think we can really be proud of the outstanding kids who still want to go into our specialty. There's a lot of hope there.
This has been a fantastic discussion and a very important one. And I want to thank Dr. Scott and Sanislo for helping to shape this conversation. And again, a huge thank you to Dr. Haller for sharing her thoughts with us today. This concludes today's episode. Please tune in for future episodes of New Retina Radio.